All right, well, hi, everybody. Good afternoon and welcome to one of our Mission Hospital patient outreach programs. My name is Dr. Bhojraj, Sanjay Bhojraj. They call me Dr. B. And today I'll be talking about a new exciting technology that we have available at Mission Hospital called TAVR. TAVR stands for Transcatheter Aortic Valve Replacement, and as we'll learn, is really a new option for patients who have a severe form of valvular disease called aortic stenosis, which historically was treated with open heart surgery. Now we can actually do these procedures through arteries in the leg, similar to once upon a time how we would put in stents in the heart. So thank you for joining us either in live person this afternoon or after the fact on the recording, and I hope that you guys learn from our talk today. So I am a consultant for Edwards Life Sciences. I'm not being compensated for the presentation today, so just get that out there. For those of you who might be physicians or healthcare workers in the audience, healthcare providers, there's no educational credit, no CME or CEUs assigned to this talk. So first of all, let's kind of talk about a little bit of the lay of the land. First of all, what is the heart? How does it work? What the heck is a heart valve? So what you can see here, and what I talk about with my patients in clinic, is essentially if you think of the heart as a house that has 2 rooms on the top and 2 rooms on the bottom, they're connected by a series of doors. And those doors kind of open and close in a one-way fashion to allow for blood to flow in the proper direction. So it starts on the right side of the heart, coming back from the body in the right atrium, then goes to this pumping chamber called the right ventricle in the bottom of the heart, then goes out to the lungs. If you remember from high school biology or college biology, that's where the blue blood becomes red blood. It's not really red or blue, but that's what we like to think of it as, is red blood has that new fresh oxygen. So once it comes back from the lungs, it comes into this chamber called the left atrium, and then back into the left ventricle. That left ventricle is a major pumping chamber of the heart. And then we reach the heart valve of interest today, which is the aortic valve. So that's where blood kind of comes out of the heart and goes to the rest of the body. So I tell people it's kind of like the front door of the heart. That's where kind of things leave from inside the house and go outside. And so that is a valve then that is very important, because that is the doorway through which all the blood, all this freshly oxygenated blood, gets out to the heart, or gets out from the heart to the rest of the body to give blood flow to organs like your brain and your eyes and your tongue and your lungs and your liver and your stomach and all the muscles in between. So it's very important to make sure that we're delivering that blood flow appropriately. Now, heart valves, though, can go wrong, kind of similar to like a door. We talked about a door, these being doors between the chambers of the heart. So if you think about with a door, what can happen? Well, you've got hinges on there. Those hinges can either get frozen open or frozen shut. So if the hinges are frozen open, what happens is that you get that draftiness, like a drafty door, that wind kind of comes inside. In cardiac terms, we call that regurgitation. That's where blood flow kind of goes backwards against the grain of traffic, so to speak. The opposite problem is what we're going to be focusing on today, something called aortic stenosis. So essentially what happens is the hinges are frozen shut. So you can't open the door all the way. So you have to kind of sneak through and kind of suck in your breath to kind of squeeze through the door. Kind of similarly, when the opening of the heart valve, of the aortic valve, which should be about the size of a quarter, gets down to about the size of a drinking straw, which is what we're talking about with aortic stenosis, you can have a lot of problems. So here on the slide, you can kind of see the 2 different types of valves on the right side of the screen here. You see a healthy aortic valve, opening and closing, opening and closing. In the left panel here, you see what a diseased valve looks like. It's got calcium, it's thickened with age and over time, and it just doesn't open the same way that a normal valve should. And so again, that's all the blood that's trying to get out to all the parts of your body, trying to get through that very narrow opening, or what we call an orifice. So it can create a lot of problems, as we'll talk about in the slides coming up. So there's a large population at risk for aortic stenosis. So right now, walking around outside in the plaza out here are patients that have some degree of aortic stenosis. So it's estimated about 12.4% of people over the age of 75 have some degree of aortic stenosis. The elderly population, so what we consider from cardiology terms, patients over the age of 75, is going to continue to grow. And here you can see kind of the average growth rate of patients in this population this portion of the population continue to increase in size. Now, causes and risk factors of severe aortic stenosis. So the causes are really buildup of calcium, which just happens as a function of age. Some people are born with abnormal heart valves or variant heart valves that can cause this. Rheumatic fever, which we don't really see a lot of anymore in the United States at least, can cause this. So you had a throat infection once upon a time. You were told in your youth you might have heart problems later on. So that's something that we do see from time to time, even here in California. And finally, radiation therapy is a big one. So particularly what was called mantle radiation for the Hodgkin's lymphomas and non-Hodgkin's lymphomas, generally in the late 70s and early 80s, we see this. Now, risk factors for aortic stenosis, kind of similar and kind of different to the risk factors for all of heart disease. So certainly increasing age, high blood pressure is an issue, abnormal cholesterol, smoking is a problem. Family history can sometimes be involved. And as I'd mentioned kind of in the causes, abnormal anatomies to the aortic valve can also lead to aortic stenosis. So aortic stenosis is progressive and gets worse over time. So here you see at the spectrum from healthy all the way to severe, you see thickening, you see calcifications forming on the valve. And basically what that does, it prevents the leaflets from opening all the way. And this is something that happens to most of us, all right? So most people, as we get older, you can't touch your toes the same way you could when you're in high school. You just get less flexible. Kind of similarly with the valve, the leaflets get less flexible over time. Now, it's kind of the needle in the haystack of patients, though, that progress to the point that they need to talk about getting a valve replacement or valve procedure done. So how serious is aortic stenosis? The answer is pretty serious. Kind of serious, depends on how severe the aortic stenosis is. For patients who have symptoms of severe aortic stenosis, there's about a 50% chance of remaining alive after 2 years. So this is on the same order of magnitude as certain cancers, lung cancers, pancreatic cancers, but generally people don't think too much about aortic stenosis. And why? Because a lot of the symptoms of aortic stenosis are kind of the symptoms of aging. So if you look here, or the symptoms that we think, oh, it's just related to old age, right? So fatigue, I have to take naps all the time in the afternoon, shortness of breath, chest discomfort, difficulty walking, rapid heartbeat, swollen ankles. These are very non-specific findings, so don't freak out if you're tired and you take a nap after this. Doesn't mean you have aortic stenosis, right? But it's kind of this progression of symptoms of what I call exertional intolerance, where you just kind of feel like you're get up and go, got up and went. These are the sort of symptoms that we get worried about when we think about aortic stenosis. And then additionally, as you kind of feel that limitations, then you start to not engage in activities that you enjoy. So one of the questions I always ask for my patients is I'll say, well, how active did you feel this past Christmas? How about the Christmas before? Were you able to go up and down stairs? Were you able to do things? Or did you just kind of feel that you just wanted to stay on the couch, right? Because very subtle changes like this can be indicators of progression of disease, of aortic stenosis. So how do you get diagnosed? A couple of different options. The first one, though, and the most easy one for cardiologists or primary care doctors in general, is to hear a heart murmur. We call that auscultation, big word, right? But basically what it means, when we listen to your heart, we're able to perceive a whoosh, kind of a whooshing sound. And that's a audible representation of turbulence across that valve. So remember, those leaflets aren't opening and closing all the way. That sets up a turbulent flow in the heart, and we can hear that. That's why doctors and nurses and folks are always taking a listen to the heart when you see them for a physical to make sure that we're not hearing any changes. EKG is something that's done very frequently. For those of you who have ever had that before, we put a bunch of stickers on your chest and you get these little squiggly traces. So a lot of times on there, we can't necessarily diagnose the aortic valve disease itself, but what we're looking for is actually thickening of the heart muscle. If you can imagine, as that opening, that orifice gets narrower and narrower, the heart has to push harder and harder to get that blood out. So if you're lifting weights and you're lifting more and more weights, what happens? Well, you try to get that big muscle, right? The heart's a muscle. So similarly, what happens is over time, as it's trying to push against that fixed blockage, the size of the heart will actually increase, and we can actually see that on an EKG. Chest X-ray, we do chest X-rays for a number of reasons, shortness of breath, pneumonias, things like that. But you can see is actually signs of the heart kind of getting enlarged, or seeing calcium deposits within the heart. That's something that we can see. At the top here, echo, that's probably the most important test when it comes to heart valve disease. For those of you who've never had one before, an echo is basically an ultrasound, very similar to when we look at pregnant babies in pregnant moms' wombs, right? Except we go a little bit north, a little bit west to look at the heart. And what we're looking at there is the squeeze function of the heart, and we can actually physically see the opening and closing of the heart valves and get a measurement of how fast the blood is going through, which is then kind of an indicator to us as to how severe the narrowing is in the heart. And then finally, the most invasive test on here, a coronary angiogram or cardiac catheterization. Sometimes we'll do that procedure to actually measure the difference of blood flow and the speed and the pressure of blood flow across the valve, which we can use to kind of back calculate the degree of opening or closing of that valve. So a lot of different tests at our disposal as physicians, but I think the most important one is just good old-fashioned listening to the heart and seeing what's going on. So what are the treatments for aortic stenosis? They kind of range the spectrum here. So the first one is medicine, which is basically the cardiology equivalent of a blindfold and cigarette. There's not a lot of great medications here to help reduce aortic stenosis. So it's not as though I can give you a Drano tablet and that's going to open up your heart. Unfortunately, medicines don't really do the trick. In the bad old days, we used to do something called balloon valvuloplasty, which is where we'd actually go across and inflate a balloon into the aortic valve to open it up. It was really good for temporary improvement of symptoms. There are some patients out there that continue to do well with it, but by and large, on average, people felt an improvement from symptoms for about 3 to 6 months and then had to repeat that process again and again. On the left-hand panel here, or on the right side here, are really kind of the more modern therapies for aortic valve disease. First of which is surgical aortic valve replacement. That's actually open heart surgery to put a new valve in the O valve. And now the newcomer, the new kid on the block here, transcatheter aortic valve replacement, which we'll spend some time talking about down the road. So one of the things that is of concern to cardiologists and the healthcare community in general is that a lot of patients who have aortic valve disease that's severe just aren't getting the therapy. So upwards of 40% of patients who need valve replacement are not getting treatment. And I think that's for a number of reasons. Number one, again, the symptoms are so nonspecific. A lot of times patients don't want to report them or they just feel that it's normal aging. Number two, sometimes physicians are concerned that my patient might be too old or too sick to withstand any sort of intervention, which we'll talk about is not quite the case anymore. Or number three, sometimes people just don't see the doctor. I mean, look, 2020 happened to all of us, right? During the year of COVID, it was difficult for patients to get out and see physicians. And a lot of times what we saw were patients who are end stage, really in that severe phase coming to see us. And so I think sometimes we just kind of fall out of sync with our docs, but for whatever reason, I think there's a lot of people walking around there that might be of benefit. And here, this is just a reminder. It says, don't wait to just treat severe aortic stenosis, but really don't wait to treat any severe symptom or any light symptom, right? Just because we're in whatever phase of the pandemic that we're in right now, as you're watching this, we're currently in June of 2021. So kind of people are getting vaccinated, kind of coming out, but we don't know what August, September, October are going to hold in store. But the fact of the matter is just because COVID and pandemic and who knows what the next thing is going to be, doesn't mean that cardiac disease doesn't still exist, right? So if you have symptoms, chest pain, shortness of breath, anything, talk to your doctor, come in to be seen by a cardiologist or any of your healthcare members, your healthcare team, because we don't want symptoms to get so severe that, as happens unfortunately from time to time, we can't offer any help because things have gotten so bad. So if you're having symptoms, definitely come in and get checked out. Now, when we talk about heart valve intervention, it takes a village. So this isn't something that you go to the doctor on Monday and then on Tuesday you're being scheduled for a new valve. There's a lot of moving parts to this. I think of those old variety store shows where they'd have the gentleman kind of in the tuxedo spinning his plates and kind of coming over here and coming over here and coming over here. There's a lot of things that happen and a lot of coordination that needs to occur between someone like me. I'm called an interventional cardiologist. So I'm a cardiologist who does procedures. Our cardiac surgeons are part of the team as well. Our valve clinic coordinator, who our coordinators are here with me in the room. I'll introduce them in a minute. Nursing, anesthesia, our referring teams, imaging specialists. So just a lot of people get involved in this. So a lot of folks wanting to make sure that we get things right. And so these are, I had kind of mentioned briefly the options for aortic valve replacement. So surgery on the left-hand side, transcatheter valve replacement on the right-hand side. And both of them continue to exist. I don't think that one is going to replace the other because there are definitely situations that patients need surgical valves. There are definitely situations where patients would do better with TAVR. And so everything is a one at a time kind of decision making with this group of physicians and healthcare members that we call the heart team. So surgical aortic valve replacement, the traditional treatment therapy for this, two surgical approaches, either what's called minimally invasive or traditional open heart, requires that patients go on heart-lung bypass. The old valve is completely removed and a new valve is sewed in. So we're getting rid of all the old tissue, generally associated with a longer hospital stay, about a 4-hour procedure. And there's a risk of stroke, as there is with any invasive vascular type procedure. This is the new kid on the block that we're talking about, transcatheter aortic valve replacement. So it's a less invasive option for severe aortic stenosis. The heart continues to beat. So we don't have to put patients on cardiopulmonary bypass. The new valve actually goes inside of the old valve. So what I tell patients is when we inflate the new valve in, the old valve actually acts as like a grout or spackle kind of around, cementing that valve, the new valve, into place. So we're actually not excising and we're not taking out the old heart valve. Typically, this is associated with a shorter hospital stay and recovery time for our patients here at Mission Hospital. As of June 2021, our average length of stay is just over 24 hours. So we're really proud of that. Low stroke risk, minimal pacemaker risk. So proud of our outcomes. But generally, all the TAVR centers are showing very similar data. Procedure lasts about an hour as opposed to the 4 hours of surgery. And there's about a 1% risk of stroke when you're out from TAVR. But again, different patients have different degrees of risk, and that's all part of the calculus of what we do behind the scenes when we talk to patients about TAVR versus surgical AVR. In terms of how we do the transcatheter aortic valve or TAVR procedure, transfemoral is the most common approach, very similar to those of you who've experienced a coronary angiogram, kind of right at the fold of the hip and the fold of the groin and the top of the hip sits an artery you can see right here called the femoral artery, and that's our on-ramp into the vascular system. Now, there are some alternative ways to go about this. Once upon a time, we're doing what's called transapical, or actually puncturing through the wall of the heart on the side. And some centers are now starting what's called transcarotid, which is actually going in through the carotid artery, generally on the left side, for patients that have a lot of disease or atherosclerotic issues in the abdominal aorta. But again, not something that patients would need to worry about, but just know that there's several options of how to get to the heart, but ultimately all roads lead to Rome. So who's eligible for TAVR? So TAVR is for people who've been diagnosed with severe aortic stenosis who are experiencing symptoms. And again, symptoms, lightheadedness, dizziness, shortness of breath, symptoms of what we call heart failure, where you just feel like you can't walk or you feel congested. Passing out, we call that syncope. That's kind of a serious situation. So if you've experienced that at any point in time, that's definitely something to talk to your doctors about. And again, only a TAVR team can tell if TAVR is right for you. There are oftentimes extenuating circumstances as to why we might want to go with surgery as opposed to a transcatheter valve. Unfortunately, this animation is not playing for me, but we will, in the link, for those of you that are watching this on social media, we will connect that link. And fortunately, I think that we're really kind of working on these valves and really expanding the indications to treat more patients. In the clinic, I tell patients, in the history of humanity, there's never been a better time to have aortic stenosis than right now, because the therapy that we have is so effective, so minimally invasive. I've got patients that are walking 8 hours after having a valve replaced, which if you had told that to medical school, Sanjay, 20 years ago, I would have said you're crazy. But it's nice as a cardiologist to be able to see patients walking around and doing so well. And the whole point of this is to return you back to life. So if that's playing with your grandkids, going to baseball games, traveling with friends, biking, fishing, whatever you want to do, that's the whole goal of this, is to get you back into normal life. And it's amazing to see how quickly patients do return to activities that they forgot that they enjoyed, because now they have that energy, they have that ability to get back to their normal life. So kind of one of the newer things that we're seeing now is what's called valve-in-valve procedures. So if you had a previous heart valve placed, we can actually go in and put a new valve inside that valve and get an improvement of symptoms. For those of you who follow Mission Hospital in Providence on social media, that was one of the patients that we highlighted in anticipation of this talk, was someone who was 93 years old, that I met really just, I was at a doctor's station hearing two doctors talk about someone who they said needed to go on hospice care, which is basically symptom relief for someone who's actively dying, because there's nothing they could do for her heart valve. I kind of butted myself in and said, hey, maybe let me take a look at this patient, see what happens and see what I can do. And she was having family members fly in from Houston and kind of all over the place to kind of be with her, what they thought was the end of her life. We went in, we put a valve inside of her old valve, and within 8 days, she was just bouncing around like nothing had ever happened. So it was just awesome to see. So just know that a lot of times there are options for patients that we thought previously were not treatable. So, definitely talk to someone from a TAVR team, or if you're in South Orange County, definitely come and see me in clinic here at Mission Hospital, and we can see what options are available. So kind of rounding the quarter to conclusion here. So TAVR, very proven treatment option for multiple indications, almost 500,000 patients now, and I suspect that number is even higher, available to patients in over 70 countries. The first transcatheter aortic valve approved in the United States in 2011. And since that time, we've had so many iterations of the valve, as you can see here. That the outcomes, this is a graph of what's called 30-day all-cause mortality, so people dying within the first 30 days after procedure. And as we go from left to right, we're seeing the newer iterations of the valve. So it's like, the first version of your cell phone now to the most recent cell phone you've got in your pocket. Just think about all the different features that are available to you now that you didn't have once upon a time. Kind of similarly, when we look at the iterative improvement in these valves, we see that we went from almost 6%, so that's 1 in 18 patients dying within the first 30 days, now to 0.4%. So, 1 out of 100 patients, not doing well. But considering that if untreated, that number would almost be 50%, right? Or it would be much higher. That's a huge paradigm shift in the technology and what we're available to offer to patients. So definitely, it's been very rewarding. Here we see some data comparing surgery to transcatheter valves. So we see a decrease in mortality, decrease in stroke, decrease in rehospitalization now with the less invasive procedure. Here, again, length of stay for hospitalization. This is older data in the clinical trial here, 3 days on average after TAVR. Like I said, here at Mission, luckily we're just over 24 hours as opposed to 7 days for surgery. 2 days in the ICU with TAVR versus 3 days in the intensive care unit with surgery. But again, those numbers, I think, are evolving over time. And if you're interested in more information, certainly there's a number of organizations here. You can look us up through just Google Mission Hospital, Providence Mission, and TAVR, and our page will come up. Here's some information about the risks of procedure. And with that, I'll end. Happy to answer any questions that might come through the chat line, or certainly if anybody on the call would like to raise their hand, I'd be happy to answer any questions that you have. Thanks, guys.